I am very honored to be here today with these wonderful individuals. And as we were thinking about the social determinants of health and loneliness and isolation, it struck me as a member of the Robert F. Kennedy Human Rights Board, it struck me that these are human rights issues that we are addressing. And I think today, as we explain to you what we mean by that, I am confident that you will leave today with the same impression that I think the group that you see here on the stage feel very strongly. But before I do that, I think it would be fair, we have some distinguished leaders here. Nobody explains their current position or their past better than the individual who lives it. So I may start with first you, Mary, if you could just explain what you do and maybe your why. Why do you do what you do?
I'm Mary Greeley. I'm president of the Healthcare Leadership Council. We're a trade association based in Washington, D.C., and a rather unique organization in that our members are CEOs of different healthcare companies and organizations, both for-profit and not-for-profit, but very unique in that we represent all the different sectors of healthcare. So we have health systems, academic medical centers, we have the health plans, medical device manufacturers, pharmaceuticals, post-acute care, health information technology, like Teladoc is a member. Also Aetna and Tivity are wonderful members of the organization. So in a way, I call myself the Boutros Boutros-Ghali of healthcare, getting all of those diverse interests into the same room to collaborate, or if I can pronounce that word,
Collaboration.
I try. But they do have a shared vision of what they want the healthcare system to look like. And it's one that's very patient-centered, I would say also consumer-centered, one that is accessible. And we've done a lot of work in trying to improve that access. Also one that is of high quality and, very importantly, affordable health care. So we have spent quite a bit of time on the topic of social determinants of health. It's been an exciting time to watch this transition of really moving away from this sick care system, moving away from the hospital, moving away from the physician's office, moving away from the laboratory. And as we heard earlier, really meeting people where they are and trying to address their needs. We have done an initiative on targeting the high-need population. And we've all heard the statistic that 5% of patients are really consuming about 50% or represent about 50% of the healthcare cost. We had a wonderful experience working with Aetna and Tivity and sponsoring a roundtable on social determinants of health. And we also included many other private and public organizations, some of who are in the room here today. And so you will have seen in your reading materials this white paper, and really trying to find solutions to the issues that we're going to be talking about today. So my why is, in my first life, I was a speech and hearing pathologist and loved that work. But what I really enjoy about what I'm doing today is hopefully having a much greater impact than just that one-on-one. Although I must have to say, being able to see in real time the effects of the work of doing therapy was most rewarding. But I'm hoping to have a larger impact in working on issues like what we're talking about today.
You know, I've known Mary for many, many years, and this is the first that I learned about your past. And I will say to you, for me, you just made a significant connection. My sister-in-law, who was a speech pathologist, after my hearing had been restored, she died in childbirth 2 months later. And she gets the credit for my being here today and speaking in the manner that I'm able to speak to you today. And so I've just made a unique connection with you. Garth.
Garth Graham. I'm Vice President of Community Health at CVS Health and President of the Aetna Foundation. I lead our enterprise-wide social determinants of health across CVS and certainly what we're doing within Aetna. I would say that, quite frankly, on the CVS side, we touch 75% of Americans. We're in 5 miles of 75% of Americans. There are a number of kinds of various ways in which we have historically interacted and I think done community health, and I think we'll continue to do so. On the Aetna side, similarly, a long history working with you and others in terms of things that we've done within particularly the Medicaid and Medicare population. About 2-3 weeks ago, I'm lost on time, we announced kind of our major CVS-wide social determinants of health initiatives, and a big part of that will be targeting, in terms of what's coming next, will be targeting what we're planning on doing around the elderly population, loneliness and everything that goes along with that, because it's much more complicated than just one particular issue. You asked us to say why. I'm an academician primarily or previously. I was a cardiologist by training and in clinical practice and academics and chief of health services research at the University of Florida. But I always say that my research on issues around social determinants of health started right around when I was around 12, 13, 14. It's because I grew up in what's called the pork and beans. Actually, I was born in Jamaica and then moved to the pork and beans in Miami, Florida. And when people think about Miami, Florida, they think of the beach. We just need to drive about 5 or 7 minutes in from the beach to interact with some of the most abject poverty that you see in the United States. You see that in many urban communities where the proximity in terms of wealth to all of kind of the financial and social challenges. And so, that's how we grew up. That's how I know. That's the life I know. My friends still live there. I still go back there. Those are the people who I consider family. And I do want to make 2 quick points. I think a lot of times when we talk about these issues, we talk about kind of the them, and I like to say the us, because we're all kind of a part of these communities, one or another. When we think especially about some of the challenges facing the elderly population, if it's not us now, it'll be us in the future, because none of us ages in reverse. And so all of these components of things that we're talking about have to do with part and parcel of who I've always been. I just now get to do it in a professional way.
Thank you very much, Garth. And I want to say that, I've had a chance to interface with Aetna over the last few years now, CVS Aetna, and what you are doing to address these social determinants of health is extraordinary. And we'll share some of the stories later on, but I just want to call that out. It's very, very impressive. And Jill.
Hello.
Pleasure to have you here as well.
Nice to be here. First, I really do want to start by thanking you, Donato, and Tivity for bringing this conference together and for shining a light on these really important issues and for doing it in a way that is both compassionate and vulnerable, because I think that we often, particularly, and I'll talk about my work in the Alzheimer's community, don't talk enough about vulnerability, and we certainly don't talk about optimism and hope in general. So I really appreciate that orientation. So I am a founding board member of an organization called Us Against Alzheimer's and the president of Women Against Alzheimer's, which is our women's effort. We were founded around a decade ago by our chairman and his late wife, who really wanted to put themselves out of business in 10 years. We had a goal of changing the face of Alzheimer's by 2020. I feel really good about the fact that we've moved the ball pretty far down the field, but we have not certainly put ourselves out of business. The reason for forming a small disruptive organization in the face of a lot of activity from larger organizations in the space is because we looked 10 years ago and there were $450 million in NIH funding for Alzheimer's research. I don't need to tick off the amount of funding that this country has spent in other diseases, but as we looked at the onslaught of the disease, we saw that there wasn't a national outcry, there wasn't an understanding. And so we were really founded around that principle. The world has changed a lot in 10 years. And I will say this, just to put it in context a little bit, when I think about the longevity that we talked about earlier today and the 30-year longevity bonus we've gotten over the last century, You know, you think about the early 20th century when penicillin came around and started to really change what people were dying from, and the next thing we knew, we had a crisis around cardiovascular disease. And we've made so much progress in cardiovascular disease and in cancer and in increasing longevity, so what do we have now? We have cognitive decline in ways that we absolutely didn't understand, and it really has caught mostly all of us until the last 25 years by surprise. And so, you know, we really were founded to change that face, and what I have seen over the last several years, and I'll talk about that a little as we go on, is there's a lot of hope to be had, but we really have to change the way we think. About 5 years ago, about 5 years into our organization's history, we began to focus much more in earnest on the disparities in cognitive decline and in diseases of neurodegenerative diseases. Mm-hmm. And the first area we began was to look at women. And that really was my passion and has long been my passion. We are women, 2/3 of the victims of Alzheimer's, and somewhere between 2/3 and 75% of the caregivers. And so the number of women affected in this country is around 20 million when you think about the caregiving population and the patient population. We know that we do not know enough about why women get the disease more than men. We don't know why they die more quickly with the disease, why their symptoms are different. We do know a lot about why our social constructs have us as caregivers, but there's a lot to learn. And we have expanded that work to include a focus on African Americans and Latinos in particular, who are respectively 2 and 1.5 times more likely also to get the disease. We know that a lot of that has to do with social determinants of health, and we'll talk about that. So really our organization's reason for being is around finding an end to this disease, but doing it in a way that understands inequities and tries to ensure that we do away with them. I'll give you 10 seconds on my personal history. I started out as a lawyer. I hated being a lawyer. And quickly became a technology executive and spent about 20 years in the technology world at the very early stages of connectivity. So I ran the Washington office for AOL starting in 1996 and really understood the power of technology to change the way we communicate, both the good and the bad. After about 20 years in that space, I all of a sudden found myself with 3 young children and a mother in a 2-year diagnostic journey of Alzheimer's, and that was 12 years ago. So I have spent most of the last 10 years refocusing my career in Alzheimer's advocacy and drinking from a fire hose and learning about health policy, but I'm really energized now by the intersection of what I think are some solutions that we can find in technology to solve some of the problems that we're talking about.
Wow. All 3 of you are extraordinarily impressive, and what I would like to do now is to frame this out in a human rights perspective. And so I'd like to give you some facts, and then we'll come back with some questions. Not long ago, the issue of aging was considered, in many respects, a matter of importance for a few countries. And I want to give you just some stats as to why now this has become a global concern. The number of persons aged 60 and over is increasing from 740 million right now to about 1 billion by the end of this decade. Unfortunately, the increase in numbers has also shed light of the lack of protective mechanisms. And you're going to hear me speak later on some of the issues that I think really do border on this human rights concerns. But let me just continue here. 2/3 of the world's older people now live in low and middle income countries. And this proportion will rise to about 80% by 2050. The challenges that they face is not one that has a disparity in an even fashion. What I mean by that, there are segments of that population that can, and you heard Katie talk about it earlier, that they do have the means and they do have the financial resources to seek out medical care. But if you're living in rural America, let's focus on the United States, is that, give you an example, the Silver Sneakers program that we have 16,000 physical fitness centers in a network. And we've done that because what we've tried to create is that within a 4 to 7 mile radius, a individual living in rural America has access, we believe, to a fitness center. But access to a community health center might be 20 or 25 miles away. And so there is what I call geographical isolation. Let me continue and then we'll get to, the questions here. The Secretary General, in their recommendation to the General Assembly of the United Nations, identified 4 key areas that they believe the issues of older Americans and, quite frankly, older adults across the world, that's falling into 4 main challenges. And they are as follow. Discrimination, that there is discrimination among the older people. Poverty, violence among the older people, and a lack of specific facilities to help them with the needs for healthcare services. And so my question to you, as we demystify social determinants of health, and I have a saying in my own company, think big, start small, execute quickly. As you think about these human rights violations and these 4 key challenges and the broad range of social determinants of health, where do we begin? What can we tackle in this prioritization from your experience to really make a difference? And I don't know who wants to go first. Mary?
Well, I'll give some examples of what our members have been involved in. And I think what is really helping this whole movement is that finally our payment system is providing the appropriate incentives to get to a really patient-centered system to look at the whole patient or consumer. So I'll use Ascension Health, one of our members, the largest nonprofit, also a Catholic healthcare system. And they have participated in the Accountable Care Organization experiments within the Center for Medicare and Medicaid Innovation. And what that means is they're responsible for that patient or consumer, their entire health. And so they were running into things, and we've heard examples of this. You have a diabetic patient. They don't have a refrigerator to keep their insulin refrigerated. So Ascension wants to make that investment. If they had not been in this experiment, that would have been prohibited under our existing rules and regulations. But finally, I think our government is realizing if we're going to have a sustainable healthcare system financially, we are going to need to look at ways other than just direct medical care.
So you have, in your opening remarks, you distinguish between sick care and health care. Is that what you mean?
Very much so.
And can you expound on that more?
Well, I think sick care, we go in, we see the physician. I think Dr. Frist did a nice job of explaining that. We're doing things, we're doing lab tests, all of that. But that's within that medical system. But we're not really looking at the health and well-being of the patient, that if we're focusing on that, we can really decrease the need for them being in the doctor's office or being in the hospital.
But pay for a refrigerator. I want Garth to talk about what Aetna has done in similar...
Exactly right. What we've realized, so there are a couple of things. I want to first start off with acknowledging a key point that you made that I hope we repeat throughout this conference and throughout all discussions, this concept of human rights. That is very real for a lot of people who are invisible. Years ago, I had the opportunity to sit on a plane next to Dick Gregory, comedian and human rights activist before he passed away. And I had a million questions for him because my dad used to teach me all about human rights. And one thing he said to me was he said, human rights is about invisibility. You can treat people a certain way only if you don't think they're people and only if you don't see them. Part of what we see, particularly with not just minority communities, but with elderly communities when they're socially isolated, is we don't see them. We can walk right past them. We can go right past a house that they may be in. They can be right in front of us, but not be in front of us. And so that component of why this is a human rights issue is very real, particularly for the people who are invisible and unseen. And so that concept of coming back to it as a human rights issue, I think, is important, and I think we should continue to do that throughout not just this conversation, but subsequent conversations when we think about this from a policy matter. So what we've worked on, and I would say selfishly, to kind of in a self-promoting way, is certainly a lot of the kinds of things that connect people to each other and connect people to care. You guys have all heard the data, social isolation is like smoking 11 to 17 cigarettes a day. So it's an entity that is clinical in itself, not just social in concept. And so, this idea of how you connect people is a big part of the kinds of things that we're investing in. You alluded to this earlier on the Aetna side. A lot of what we do with our seniors is, going into homes, connecting them through social work, through care, particularly in our Medicare Advantage population, making sure that people have access to silver sneakers and Meals on Wheels and all those different kinds of partners that can aggregate and pull people together and make them connected. And again, in that connection, what we do, we make them visible. And that's where we go back to this concept around human rights and around this idea of how we treat people as people. And so whenever I hear people talk about human rights, I always think about that concept, because going back to where I started about myself, you can drive through, I-95 goes right through our neighborhood on 7th Avenue in Miami. And part of that invisibility is millions of people drive past that every day, and they don't understand that the lives that the people that are living on either side of that highway is about 50, 100 years behind in terms of life expectancy of many different communities. So that's why these things are civil rights issues, because these are all people, these are all individuals, they're all part of us, and it's about how we make sure that they're connected. But I am particularly proud of our strategy, which is around deploying all of these various ways in terms of preventative connectiveness, and particularly how we deploy our case management system through this ACC program we have, and all these different kinds of things. And I think all of that is a strategy of treating people like people.
I want to just ask a follow-up question, and I think Katie and I alluded to it, and I think many of you would probably resonate this. For years, many people didn't want to hear from their health plans. And so what are you doing to change that? Because I firmly do believe now that the health plans have a quintessential opportunity, and they are at the front and center of reaching out to these members. So how do you get the member to kind of change what has been years of, I don't want to hear from my health plan?
Yeah. Honestly, the health plans have been evolving. I was heartened the other day, I picked up a Forbes article that said, health plans leading the way on social determinants the government should follow. And I was like, when does that start happening? I was like, let me send this to everybody. And it was using examples of the kind of things we do, and it is true. Plans, ours and others, have been leading the way on this particular issue. We've been doing it for a long time. What we've found is that by being present in people's homes and communities, you become a part of not just their healthcare, but a part of their daily lives and their decision making. And that in itself makes them healthier. So certainly there is a business, as much a business aspect to this as it is a social aspect. Through our Aetna Community Cares program, which is something I'm particularly proud of, we have this team of case managers that tie people to local assets, whether it be local Meals on Wheels, local in terms of silver sneakers, whatever that particular programmatic activity is, and it's made up of people from those communities. Examples like that, I think, is why plans have changed how they've been seen, particularly in these kinds of topics, and I think highlight the role that we all can be leaders. It just takes that energy and commitment.
Joe, you're in a very, first of all, a lot of respect and admiration. I don't think there's an individual in this room today who has not experienced the loss of a loved one to Alzheimer's. My brother-in-law just 2 months ago passed away after having a diagnosis at age 50. He lived for 20 years. But one of the things that I remember about that situation is how he and my sister were discriminated. The minute the neighbors heard that he was living with Alzheimer's, they were calling the police and saying, make sure you, and so how do we educate the community in terms of not discriminating against those who are enduring a chronic disease or are aging with dementia? What has been your experience? Because to me, that is another variable in addressing the social determinants of health.
Yeah, I mean, I think what you're alluding to is our discrimination against older people in general. Discrimination against people with dementia is even worse and by orders of magnitude for a variety of reasons, not the least of which is their own fear. Putting yourself in front of a person with dementia really makes you think of your own cognitive health and your own mortality. And like we have seen with other diseases, with cancer, 50 years ago, people back away. And so demystifying and destigmatizing the disease, I think, is really critical. And there are a couple of really extraordinary efforts, one of which started in the state of Minnesota, Dementia Friendly Minnesota, and then became Dementia Friendly America, is really going in community by community and educating people not only to destigmatize, but also to allow people to live longer independently in their communities and have the people who are around them, whether they're clergy, whether they're police officers, whether they're dry cleaners or beauticians, to understand how to navigate around a person with cognitive decline. The other thing is that, one of the things that is most critical to the work that we're doing now is that we've seen a lot of failures in our fight to find a disease-modifying treatment. But we know that most of those therapies, if not all of the research now, is being targeted to very, very early intervention. No one in this country is diagnosed or informed of their cognitive health early in that process. What we need, because there's a lot that can be done both in the drug space and in the caregiving space, is once we are more courageous about talking about cognitive health, because it is something we're all going to experience. We all have different manifestations of our cognitive health throughout our lifespan, is that we have to recognize that lots of people with very mild cognitive decline are really very active members of the community and can remain that way for a long time. And when we take away their independence or make assumptions about them, we also undermine that independence and their ability to continue to navigate their lives. So we're actually undermining how they're even able to live today.
That's a very good point.
For all three of you, we believe that this is a human rights issue, and yet I think you heard today in terms of some of the messages that are coming across that we're living in different times right now. Certainly, the Universal Declaration of Human Rights, Article 25, states that healthcare is a basic human right, and yet we still live with a significant of the world population not having access to healthcare. And so one would kind of argue to say, listen, all these social determinants of health are fine, but we don't even have access. So how do we, when you think about it, how do we address this in a way that really can begin to not only honor the rights of every individual, because I do think that healthcare is an absolute right for every individual. And when one person has been neglected that right, we have violated the Declaration. So how do we put this into a tangible movement that can really help to change the tide to say, this is a right, yes, for access, but it's also a right to address, and I like what you said, the holistic. So we have a problem with access, but we also have a problem that we really haven't delivered on that commitment to keep the population healthy. So how do we bring them together?
Can I just make a comment about the paradigm? Because I think, we put out a paper earlier this spring called The Optimal System of Care for Brain Health, really trying to figure out, both from a policy, a provider, a payer, and a consumer, I won't use the word patient, a consumer perspective, how to move the needle. And we hired an expert, and the surprising feedback that we got was around starting with the consumer. And so I just want to talk a little bit about that, because I think that even by virtue of our nomenclature, the way we talk about healthcare, We aren't integrating the services that you provide through Tivity with Silver Sneakers and our feeling of wellness and empowerment. So when we think about human rights, we have to have human empowerment, and we have to have a society that comes from a place, and this is certainly not easy across all of the heterogeneity of our society, but to even begin to say we're not, and Senator Frist talked about this earlier, we're about health. So what does that look like? So when I am entitled to health, I don't just interface with my health care system, because people don't interface with our health care systems in this country for the most part unless we're sick. Indeed, if we think about our Medicare population, where people have a right to an annual wellness visit in Medicare, 20% of people in this country utilize that benefit. So 80% of seniors who can go and get an annual wellness visit and think, how do I know if I'm healthy, just don't even go into the healthcare system. There's, for a variety of reasons, lack of access, lack of trust, lack of experience, language barriers, all sorts of reasons why not. But we don't think of ourselves from a wellness perspective. And so we haven't integrated these giant industries, like a wellness industry in this country, where young people are spending enormous parts of their disposable income on wellness, and yet it's totally disconnected from our healthcare system. And so I think some of this is in developing a movement that speaks to people and gets them to really change the way they're interfacing with the system.
And what I've always said is that I think it's insulting when you say to a consumer to get engaged when they're sick. They are engaged. What you want them to do is to be empowered.
Right.
Exactly.
Right.
And I think what you're saying is that health and wellness is about empowering. And when you are sick, you get engaged. Mary, what has been...
Well, and I think part of this is getting them engaged a lot sooner than we have in the sick care system, and empowering them early on so that they're helping to manage their health care long before it gets to the critical stage. I always, and maybe it's being in Washington and having to lobby various members of Congress, all right, what's in it for them? Why should they support this movement? Well, if you want a sustainable Medicare program, Medicaid program, you're concerned about the budget deficit, if we can do these early interventions, we know that we can either delay the onset of chronic disease or prevent it entirely. And that will result in huge savings to the program. And I view this as a win-win. It's a win for the consumer or patient if they're at that stage, and it certainly is a win for the fiscal viability of these programs as well. So I think we're seeing a shift, and you can make the business case for it, but you can also make kind of the mission-oriented case for it as well. It's good for the patient, good for the consumer. And at the end of the day, it will help more people and improve accessibility if we can improve the affordability as well.
So what we're really talking about is transactional leadership and transformative leadership. We still have to manage the sick population, and that is the transactional part. But we've got to transform into a healthcare system that is going to be managing all categories, those who are still healthy, those who fall into the stable chronic bucket, and those who are in the severe chronic. And so, Garth, the question to you is, if you're a large employer, you're sitting back and saying, this is like more investment now. We've got to put more money into these, holistic, wellness programs. That's going to hit my bottom line. How do you bring them along?
Yeah, I want to go back to one point you made and to tie that in. When you said, people are looking, we should stop saying that we should engage folks because they're looking to be empowered. That resonated with me. I remembered when I was growing up, we'd always have these people come to us in our communities and say, we're here to help you. We're like, we're not looking for saviors. We're actually just looking for people to empower us. And that's what you see, particularly in rural America. There's a spirit there where, again, no one's looking for people in DC or other places to save them. They just want to be empowered and have the same kinds of rights and abilities and capabilities that they see and that others have. And that's particularly important because our strategy has to be local. And so even though we have the vantage point of thinking through life particularly on the health policy end from DC or some other event all healthcare is local. You know, all the numbers that we deal with are aggregate of local numbers that build up into a national tapestry. And so particularly in terms of our strategy, it is just that, it's to go very local. And what we have from the CVS and Aetna standpoint is the ability to be present in local communities in a way that no other major health system, company, organization, or strategy is. And so we can implement and do things that others can and that we know we can do. And those are the kinds of things we're doing in terms of transforming healthcare from the local level up. So I see this as building from the grassroots back to the treetops and making communities stronger. But to tie that into your other point in terms of understanding the wellness concept on the employer side, again, just like I said in terms of understanding communities, I think even on the employer side and employee side, it is about education and empowerment. It is about kind of empowering employees to make the right kinds of decisions that make themselves and their families healthier. On the Aetna side, you know, we started doing a lot around mindfulness. And it was kind of interesting because you ask people who know me, the last person who would engage in mindfulness is this guy right here. But, you know, as I started to learn as an employee more about it and kind of more of the different dynamics, I actually felt empowered. And I mean, I'm a cardiologist, for goodness sakes. I mean, these should be things that I would be doing. I should be doing it already. But, you know, people, we underestimate what education, and again, that concept of empowerment does. And now it's a part of my daily health practice. It's a part of who I am as I got to learn more and understand more. And so I'd use the same example for employees that I started off by saying about communities. Do not underestimate the power of local communities, particularly local rural communities.
So I want to bring this back to the human rights variable, because I put out 4 challenges that the United Nations has identified as human rights violations among the older population. And they are the discrimination, it is the abuse, it is the financial struggles that there are a good portion of our seniors who are living in poverty, and of course the lack of health services. What investments, if elephants could fly and you had a budget that you could invest into whatever area that could help to move the needle to correct those 4 challenges, where would you put your dollars? Let's start with Joe.
Well, I mean, I have an answer that I hope doesn't appear too political, but I think we're having a conversation about healthcare in this country, and we're not talking at all about long-term care. And so whatever side of the political aisle you're on, and if you're listening to the conversation about Medicare for all, you still have a giant elephant in the room, which is to say, and this is very, very true for Alzheimer's, but it is true for a number of chronic conditions, and that is we do not think of the activities of daily living and the ways in which we need to care for people, and really it is true. It is just population-wide. There are more needs as you age, as part of that system, as part of a system that we have to invest in, and where there is a right for people to have that care. So, you know, you have millions of seniors who have to run down the money that they do have, the money that they have saved in order to be able to go on Medicaid, where there is some coverage. I'll give you a personal example. So I've been caring for my mother for 12 years. I feel blessed every single day to have the resources to care for her in a really fantastic way. She has been on hospice a couple of times. She keeps graduating. It's a long story in and of itself. She's a fierce lady. But she went back on hospice a month ago, and it reminds me that all of the money that I spend on diapers and a number of other things she needs for her care all of a sudden shows up. And I don't have to pay for it because she's supposedly, you know, sort of 6 months from dying. Now, no one would suggest that we provide hospice services to people for 20 years, but we're not having that conversation at all. So one investment that I would make is in really unpacking what the cost of that looks like, how we have people understand that a lot of these chronic diseases would be much better managed if people were helping remind people to take their medicine for their blood pressure or to manage their sugar, so that they don't have unnecessary hospitalization, so that they are not living with chronic conditions. So I think that's one area. I don't know what the solution